Growth, health, and nutrition in Latin America. We have divided it into two parts: LatAm, a panoramic overview, and LatAm, processes and challenges. It is important to consider the great diversity and variability of the region from several angles: geographic, ethnic, level of development, and we are going to consider maternal mortality, infant mortality, pregnancy in adolescents, COVID mortality, life expectancy, poverty, and Human Development Index. First of all, the millions of persons that live in the region. Brazil, which is the largest country, of course, has the largest population, followed by Mexico, and then the countries in light blue: Venezuela, Colombia, Peru, Argentina, and followed by the countries in yellow, which have the smaller populations. But this is very important, the great geographic variability of the region. For instance, in Mexico, more than 50% of the population lives above 1,500 meters above sea level. Venezuela, only a very small portion lives above the 2,000 meters above sea level. Peru, more than 30% lives more than 3% meters above sea level. In Colombia, Bolivia, Ecuador, northern Chile, and northwestern Argentina, a high percentage live more than 2,000 meters above sea level, and a smaller proportion, 3,000 meters above sea level. This is very important because the IBP, International Biological Program, studied populations that lived in the highest altitudes of the world, the Himalayas and the Andes. And they studied the causes of short stature, which were hypoxia, cold, low humidity, and malnutrition. And the effects were mostly prenatal retardation, adverse placental effects, also pubertal retardation, but basically prenatal retardation. This is a map of the whole continent that shows the differences in ethnic population, the Caucasian in light beige, mestizos, Indo-American, mulattoes, Black, Oriental, Asiatic, Indian, Garifuna, which is called by some people, but we call them Zambos, and other mixtures. And one can see that in Canada and the United States, North America, not Mexico, it's basically Caucasian. Also, the southern part of South America, Argentina, Chile, Uruguay, and Paraguay. But the rest of Latin America is an admixture of some sort. And that Latin America is an admixture of Indo-Americans and Africans and Europeans because of the immigrations of several centuries. This mixed genetic analysis has been performed in Venezuela by Rodríguez Larralde and Castro de Guerra. And they determined that in the country, 59% are European descendants, Caucasian, Portuguese, Spaniards, Italians, 28.5% Indo-American, and less than 13% African. But this, of course, varies. It varies with the social strata, and it also varies with the region of the country. If we compare Venezuela to Colombia, Ecuador, and Peru, not only the mixed ethnic groups, phenotypic, but also the phenotypic Caucasian studied, one can see that predominantly we have Caucasian population, but also we have African and Indo-American in all the four countries. It is completely different when one studies Argentina, for instance. Argentina's, the Buenos Aires region, is basically Caucasian, more than 80%, with very little Indo-American and African. Very different from the North Occidental region, which is next to Bolivia, Jujuy, Salta, Tucumán, Catamarca, where there are many African and Indo-American genetic descendants. We must define the demographic transition, and it is the same as in all parts of the world. The evolution of populations consists in the decrease in the young population and the rise in the aging population due to the decline in the birth rate and the increase in life expectancy. And the demographic bonus, which is a very important concept, is the period in which people of productive age outnumber the dependent population, which are young people and older adults. These are the evolution of the pyramids, as in all parts of the world. The reduction of the base of the pyramid is produced by a decrease in fertility and birth rate. The gradual increase in the vertex of the pyramid is due to the increase in life expectancy. And the more symmetric pyramid is due to the increase in the demographic bonus. This is typical of very mature populations, and there are some countries in Latin America that are mature and that have this symmetric pyramid, the same as other developed countries in the world. Maternal mortality is high in Venezuela, Bolivia, Nicaragua, Haiti, and Guyana, low in the southern part of South America, for instance, in Chile, Uruguay, in Argentina, but also in Costa Rica, Mexico, Cuba, Belize, as low as Canada and the US, and many countries are intermediate. Infant mortality, again, is high in Venezuela, Guatemala, Dominican Republic, Guyana, Bolivia, Haiti. It is low in the southern part of South America, Argentina, Chile, but also in Cuba, in Costa Rica, in Mexico, Belize, and intermediate in the rest of the countries. Adolescent pregnancy is a very big problem in the region. It is very high, Guyana, Honduras, Ecuador, Panama, Nicaragua, Venezuela, and the Dominican Republic. It is low, again, in the southern part of South America, but also in Mexico. It also in Puerto Rico, of course, in the United States, and even in Brazil, and intermediate in many countries. COVID mortality does not follow any sort of pattern. It may be high in underdeveloped countries and also high in developed countries. So we are not going to stop in this part. Life expectancy is low, again, in Venezuela, Nicaragua, Guatemala, Bolivia, Guyana, and Haiti. High in the southern part of South America, for instance, like Chile, but also in Cuba, in Costa Rica, in Panama, the same as Puerto Rico and the United States, and intermediate in the rest of the countries. Poverty is high, Haiti, Nicaragua, Honduras, and Venezuela, low in Argentina, Uruguay, and Chile, and intermediate in many countries of the region. The Human Development Index is very important because it not only takes into account the life expectancy, but also the per capita income and also educational level. And it is low in Haiti. It is high in Cuba, Mexico, Peru, Colombia, Brazil, Ecuador, Dominicana, Paraguay, Bolivia, and Venezuela, very high in Chile, Argentina, Uruguay, Panama, and Costa Rica, and intermediate in the rest of the countries. This is an example from Venezuela, but we believe that most of the countries of the region went through this sort of idea, that diarrhea, tuberculosis, and malaria, the infectious diseases, were the most prominent in the 1940s. And heart disease was only the fourth cause of death. But from 2000 on, the first causes of death are heart disease, followed by cancer, and diabetes mellitus is the third cause. All causes of death from the developed nations of the world. Growth in the region and health and nutrition in the region, we have divided into two parts. The first 1,000 days of life and food transition and the double burden of nutrition. The adult height of men and women, according to the NCD risk factor collaboration with the WHO, the tallest men of the region are from Argentina, and the tallest women of the region are from Uruguay. But all these countries, from Argentina to Mexico in men, and from Uruguay to Ecuador in women, are above the mean. So the region does not have this great difference in adult height. The 6 national surveys are here in the countries you see in the bottom part: Argentina, Colombia, Cuba, Ecuador, Peru, and Venezuela. Argentina, Colombia, Cuba, Ecuador, Argentina, Cuba, and Venezuela were done in the 70s and the 80s and included all the regions of the countries, urban and rural areas. Colombia was performed in 2015 in children and adolescents of middle and upper strata of large urban areas. So they were sort of an elite. Ecuador was undertaken from 1999 to 2012, following a similar methodology to the first 3 surveys. And Peru was done between 2009 and 2011 in children and adolescents of the coastal Amazonian regions, but included those who lived in heights above 4,000 meters above sea level. So as you see, they are not completely comparable, yet we thought it was worthwhile to compare their growth during childhood and adolescence. And here we have the comparison of Argentina, Venezuela, Colombia, Ecuador, Peru, and Cuba to the WHO. WHO is in black, and we see Argentina in red, who are also very tall, and followed by Venezuela and Cuba. Venezuela and Cuba, like Caribbean countries, are very much alike always. And the smallest are the orange and the brown, which are Ecuador and Peru, but basically for genetic ethnic regions, ethnic reasons, not for other reasons. And when we compare the BMI, it is important because it is the indicator that is used to define children as undernourished or overnourished. We see the great variability. Again, the WHO is in black, and we see countries that are beneath the WHO and that are above the WHO. Venezuela and Cuba are beneath the WHO, and in red is Argentina. They're overweight. They know they have this problem. And even higher than the children, adolescents from Argentina are the corresponding from Peru and Ecuador, but for different reasons. It is a genetic reason because of their ethnic structure. And now we have the first 1,000 days of life. Problems and initiatives. And we see here from pregnancy until 2 years of age, as everybody knows, are the first 1,000 days of life that are very important. We have many problems. Malnutrition during preconception period, during pregnancy, inadequate control of pregnancy. 4 visits average. Some people arrive at the moment of birth without having seen a doctor. Adolescent pregnancy, which is high, very high. Short stature of mothers. Cesarean section births, which are rising. Prematurity 12 to 13%, low birth weight 9%. Less than 6 months of breastfeeding 33%. Inadequate feeding practices, few guidelines for medical and paramedical personnel in more than 60% of the countries. And here we have the initiatives. We have divided them in policies for prenatal care, nutritional supplementation, high-risk prenatal clinics, handbook for the first 1,000 days of life, child care from birth to 2 years of age, promotion and legislation regarding breastfeeding, guidelines for medical personnel in the first 1,000 days. And here we have our Venezuelan consensus, which includes early nutritional programming, nutritional risk factors, nutritional evaluation of pregnant women, complementary feeding, prenatal and postnatal growth, importance of microbiota, evaluation of the newborn, all in one handbook that we are using. And now for the nutritional transition, for the food and nutrition transition. It is a substitution of the traditional diet for one high in processed foods, saturated fats and sugars, and low in vitamins and minerals. It is a multifactorial process of socioeconomic and cultural changes in the region. Barry Popkin in 1993, as an extension of the demographic transition theory of Thompson and Caldwell and the epidemiological transition of Omran, proposed the concept as a result of urbanization and economic process. What are the causes? Of course, availability of processed foods, high frequency of feedings outside of home, but the most important are the low physical activities in cities that have an anarchic and highly urbanized milieu, and less time of women who work for traditional cooking. There are two types of nutrition, and the accidental type that presents a gradual change, and the developing countries, countries that have a moderate or low income, that present an accelerated change. And then the double burden of nutrition appears. It is important to point out that there is a great regional heterogeneity. Why? Because this occurs at different moments and velocities. An example, Chile and Cuba have been in post-transition for many, many years. Before talking about the double burden of nutrition, let us point out that not all is due to this nutritional transition. For instance, this work done by Larrea and Freire in comparing Ecuador, Peru, Bolivia to Colombia, they found that Ecuador, Peru, and Bolivia were very similar, with 21% short stature due to high altitudes, to the ethnic populations, to the low socioeconomic levels. And Colombia was quite different because it had less inequality and contrast. Colombia is much more like Venezuela. And here we have studied nutritional transition and the double burden of transition in 3 levels. The individual level, for instance, a woman who is overweight and has anemia, household level, an overweight mother and malnourished child, and the population level, an overnourished boy and an undernourished boy. The double burden of transition was first studied in the Satellite Symposium in Granada, Spain, in 2013, where Argentina, Brazil, Chile, Colombia, Cuba, Ecuador, Guatemala, Mexico, Peru, Uruguay, and Venezuela presented. And this was published in the American Journal of Clinical Nutrition, where chronic malnutrition, short stature, was highest in Guatemala, almost 50%, Ecuador, 25%, and lowest in Chile, less than 2%. Overweight was most prevalent in Chile, Uruguay, and Mexico, a big problem. The combination of an overweight mother and an undernourished child, although not related statistically, was very frequent, as well as overweight in women, reaching 80% in some countries. Rivera proposes the need for policies that address both kinds of malnutrition at the same time. A second symposium was Satellite Symposia was held in Buenos Aires in 2017. And it studied malnutrition in all its forms, by socioeconomic level, by ethnicity, and by educational level. And it was analyzed, chronic malnutrition proved to be strongly related to low educational level, 15 to 25% higher prevalences, anemia found in low socioeconomic levels, and the finding of overweight in low socioeconomic level women and high socioeconomic men was found in some countries. It was published in the Public Health Nutrition Journal. The double burden of nutrition is very important because the metabolic syndrome may exist. And this is a very easy way to find out, which is the waist circumference measurement. In Latin America, the risk factor is a waist circumference of more than 90 centimeters for men and 80 centimeters for women. Why? Because comorbidities of overweight and obesity may be found with abdominal obesity, such as dyslipidemia, hyperglycemia, and hypertension. And this is very related to the inactivity of the region. The inactivity of the region is in men 30% and in women 42%. And all these countries that you see, from Brazil to the Bahamas, are all above the median for inactivity in the region, a very big problem. This was a study performed in Argentina, Brazil, Chile, Colombia, Costa Rica, Ecuador, Peru, and Venezuela. And in this study called ELANS, many features were studied, but one of the most important was the EPAC method, which is recognized all over the world for measuring inactivity. And in the region, it was found that only moderate and sedentary activity was to be found, that vigorous activity was very low in general. The double burden in Venezuela has changed. Due to the complex humanitarian crisis of the past decades, the double burden has changed because undernutrition has doubled, in some cases tripled, and overweight has diminished. As one can see here in Fundación Bengoa data for children who had undernutrition and who had overnutrition, where it is low now, and undernutrition is much higher. And in Kenya, where one can see that undernutrition has risen and overweight has diminished. Finally, and this is very recent data, we have children, the adolescents from Kenya, and we also have malnutrition from the Hospital de Niños JM de los Ríos, which is our main children's hospital. For instance, the children and adolescents from Kenya, undernutrition in red has risen dramatically and overweight has diminished. Also, adolescents and non-adolescent women in orange and in blue, in dark blue, have risen, are now most seen in Kenya in the first visit that is done to pregnant women. So that means that overweight in pregnancy is low and that underweight in pregnancy is high. This is a very big problem for the country. And malnutrition in the Hospital de Niños JM de los Ríos shows that kwashiorkor has risen, as well as the marasmatic type of undernutrition, and that excess has fallen. Many thanks to all these persons. Some of them work actively in the field. Many of them are medical doctors. Others are specialists in nutrition, and many are technicians for their help in putting this together. Thank you.